Welcome to this deep dive all about scaphoid fractures. It's definitely a super important topic for the FRCS plastic surgery exam. We'll be hitting those key points today about, you know, incidence, anatomy, evaluation, and treatment. You might want to grab a notebook because we're going to be moving pretty quickly through all this material.
All right, so let's just jump right into it. Starting with the basics. The scaphoid is like the most common carpal bone that gets fractured. We're talking 70% of all cases. And we see these fractures a lot in young men. So think like 15 to 30 years old.
Why that age group, though? Why are they more likely to get these?
Well, it's probably because they're the ones doing, all the high impact activities, the ones more likely to fall and land on an outstretched hand. But the good news is scaphoid fractures, they're actually pretty rare in children. That's because their carpus is still cartilaginous. And when they do happen in kids, the fractures are usually more distal.
Okay, so now let's think about anatomy for a second. The scaphoid, it's got this really distinct shape. It kind of looks like a bean or a peanut.
Interesting. Why is that shape so important? Well, that shape is important because 80% of the scaphoid's surface is articular. So that means it's covered in cartilage and it's involved in all the joint movement. But there's this thin little strip across the dorsal waist that makes up the other 20%. And this part is vital because it has the nutrient foramina. Those are responsible for the blood supply to the bone. And don't forget, the scaphoid is the only bone connecting the proximal and distal rows of the carpus. It's like a bridge between them.
So if we think about that blood supply for a minute, that seems pretty important for understanding all those fracture complications. Can you break that down for us?
Sure. So the scaphoid gets its blood from two main branches of the radial artery. There's the scaphoid tubercle branch. That one supplies the distal 20% of the bone. And then you've got the dorsal ridge vessels. These are tiny little perforating branches, and they supply the proximal 80%.
Okay, so the proximal 80% is relying on these tiny vessels. Does that mean anything for us?
Yeah.
Especially when we're thinking about fractures.
Absolutely. There's a really important point here. There are no perforating branches supplying the scaphoid proximal to the waist. So that means the blood supply to that area is retrograde.
So the blood flow to the proximal pole is like reversed almost. It's more vulnerable.
Exactly. That retrograde flow is what makes proximal scaphoid fractures so tricky. They have a much higher risk of complications like a vascular necrosis, delayed union, and non-union.
Got it. And what about how the scaphoid moves the wrist? What happens if a fracture messes that up?
So the scaphoid works with the scapholunate ligament to make the proximal and distal carpal rows move together. But when you have an unstable scaphoid fracture, it throws everything off. The lunate and the proximal scaphoid, they extend, but the distal scaphoid flexes. We call this dorsal intercalated segment instability, or DISI for short.
And so what does dizzy do to the wrist over time?
Basically, DISI changes how the carpal bones bear weight, and that can lead to degenerative disease. And eventually, you might see something called scaphoid non-union advanced collapse,
Yeah.
or SNAC wrist. It's a pretty serious consequence if you don't treat the scaphoid problem.
SNAC wrist.
Mhm.
Sounds serious. So it seems like knowing how these scaphoid fractures happen in the first place is super important if we're going to diagnose and treat them properly. What are the most common ways people get these injuries?
There are two main mechanisms we see, hyperextension and axial load. Hyperextension is like when you fall onto an outstretched hand and your wrist bends back, like way back 95 to 100 degrees. That puts a ton of force on the waist of the scaphoid.
So the force is all concentrated in a small area leading to a fracture.
Yeah, basically the proximal part is stable, but the distal pole isn't supported, so you get this tensile failure right at the waist. Now, axial load is more like a direct hit to the hand, like if you punch something.
So it's like the force travels right through the bones and into the scaphoid.
Exactly. The impact goes from the second metacarpal through the trapezium and trapezoid, and then boom, it creates a volar shear force on the scaphoid's distal pole. And that often causes a fracture, usually at the waist.
Interesting. So knowing those mechanisms really helps you understand all the forces involved. Now, how do we evaluate a patient if we think they might have a scaphoid fracture? Where do we even start?
Well, the history is super important. We need to know how old they are, if they're male or female, if they're right or left-handed, what they do for work, how the injury happened, and how long ago it happened.
What about the physical exam? What are we looking for there?
So look for pain on the radial side of the wrist. Look for swelling and bruising. But remember, these signs can be really subtle.
Are there any specific tests we should do during the exam to help us pinpoint a scaphoid fracture?
There are three key things to check. First, palpate the anatomical snuff box. That's the little area on the back of the wrist between the tendons of the thumb and index finger. If it's tender there, that's a strong sign that there might be a scaphoid fracture.
Okay, what else should we check during the exam?
Then you want to check for tenderness over the volar scaphoid tubercle and or the dorsal scaphoid with the wrist flexed. This can help identify any problems with the proximal pole. And remember, that's the area that's more vulnerable because of the retrograde blood supply.
And the third thing to check.
The last thing is axial compression. You apply force through the first metacarpal. If there's a scaphoid fracture, that'll usually cause pain.
So let's say we suspect a scaphoid fracture. What imaging do we need to order to confirm it?
Radiographic imaging is what we start with. We need 5 views of the wrist: posterior anterior, PA, lateral oblique clenched fist, PA, and a dedicated scaphoid view.
Why so many views for such a small bone?
Each view gives us different information. The PA view is the standard front-to-back image. Lateral view shows the wrist from the side. Oblique gives you an angled perspective to see certain fractures better. Clenched fist PA forces the scaphoid into extension, which helps show waist fractures.
Yeah, what about that dedicated scaphoid view? Why is that one so important?
The scaphoid view is taken with the wrist in a specific position, fisted, semi-pronated, and ulnar deviated. It gives us the clearest picture of the scaphoid bone itself. This helps us catch those subtle fractures that other views might miss.
So we have a patient we think might have a scaphoid fracture, but their initial x-rays are normal. What should we do?
In that case, we'd immobilize the hand with a thumb spica splint, and then we'd repeat the exam and imaging after 14 to 21 days. Sometimes fractures are just hard to see right away.
So even if those first x-rays look normal, we shouldn't ignore our gut feeling if the history and exam point to a scaphoid fracture.
Exactly. And there are other imaging tests we can consider if those follow-up x-rays are still unclear.
Like what? What are some other options?
A bone scan can be helpful if the x-rays are normal, but we still strongly suspect a fracture. It involves injecting a little bit of radioactive material that's attracted to areas of bone activity. So if there's a fracture, the scan will show increased uptake in the scaphoid.
What about a CT scan? When would we use that?
A CT scan is really helpful when plain x-rays show a non-displaced fracture. It gives us very precise details about the fracture line so we can assess how much it's displaced or angled.
So it's more helpful for planning surgery.
Yeah. And when it's not in acute setting, it's usually preferred over MRI because it's more accurate for defining the bone alignment.
And what about MRI?
MRI is great for detecting acute fractures and assessing soft tissues like ligaments. It's often preferred over CT in the acute setting, especially if we think there might be ligament injuries along with the fracture.
But MRI has some downsides, right?
The main downside is cost. It tends to be more expensive than CT, which can make it impractical sometimes. All right, so now let's talk about treatment. How do we approach non-displaced scaphoid fractures?
Yeah, let's start with that. Then we can get into displaced fractures.
Okay, so the good news is most non-displaced fractures heal well with just immobilization.
What's the usual protocol for that?
Typically, we put the patient in a long-arm thumb spica cast for 6 weeks. Then they wear a short-arm thumb spica cast for another 6 weeks.
Is there a difference in outcomes between the long and short arm casts?
Some studies suggest that short-arm casts might lead to higher non-union rates, so we generally prefer to start with the long-arm cast.
Are there any times when we'd consider surgery for non-displaced fractures?
Yeah, there are 2 situations. First, if the patient has a really demanding job or lifestyle where they can't be in a cast for 12 weeks, we might consider internal fixation, like percutaneous screw fixation. And second, we recommend internal fixation for proximal pole fractures because they have a higher risk of non-union and a vascular necrosis. Remember that retrograde blood supply?
So those fractures need more aggressive treatment to make sure they heal right. All right, so now what about displaced scaphoid fractures? How do we handle those?
All displaced scaphoid fractures need surgery.
What are the usual techniques we use to fix them?
Percutaneous screw fixation is pretty common. It's a minimally invasive procedure where we just insert a screw through a small incision to stabilize the fracture.
And what about open reduction and internal fixation? When do we choose that?
We usually do open reduction with screw fixation for more complicated fractures, like if there's a lot of displacement or the bone is broken into multiple pieces, or if there are ligament injuries too. In those cases, we need to actually see the fracture and move the pieces back into place. We make an incision to do that, and then we fix it with a screw. There are different types of screws we can use. Some are solid, some are cannulated, and they're designed to compress the fracture site for better stability.
How do you decide whether to go in from the volar or dorsal side for open reduction and fixation?
It depends on where the fracture is. For waist and distal fractures, we usually prefer the volar approach. That helps us protect the blood supply to the scaphoid. Remember, that's super important for healing.
And for proximal pole fractures?
For those, we usually use a dorsal approach because it gives us better access to the proximal pole so we can see it better and fix it properly.
Okay, so now let's talk about some of the things that can go wrong after a scaphoid fracture, even with the right treatment. What are some of the potential complications?
One complication is malunion. That means the fracture heals, but it doesn't line up correctly. The most common type is a humpback deformity. That's where the distal pole flexes and the proximal pole extends. So you end up with a scaphoid that's bent out of shape. And that can lead to chronic pain, limited mobility, reduced grip strength, and even arthritis.
So what do we do if that happens? How do we fix a humpback deformity?
The treatment for that is kind of controversial. Some surgeons like to operate early on to correct it with an osteotomy and bone grafting, but others prefer to take a more conservative approach and avoid surgery. The best way to handle it really depends on the individual case.
What about delayed union? That's when the fracture hasn't healed after 4 months of immobilization. How do we manage that?
That one's also debated. Some surgeons will keep the patient immobilized and just watch and wait. Others will go ahead and do surgery with open reduction and internal fixation, or ORIF. Just like with humpback deformity, there's no single right answer for how to manage delayed union.
And then there's non-union. That's when the fracture just doesn't heal at all. What are the long-term consequences of that?
Non-union can lead to arthritis and eventually SNSC wrist deformity. It's really important to diagnose and treat non-union early on to prevent those long-term problems.
That brings us back to that SNAC wrist we talked about earlier.
Yeah.
It seems like that's where a lot of untreated scaphoid problems end up.
Yeah, that's right. And that's why recognizing and treating non-union quickly is so important if we want to preserve wrist function and prevent long-term disability.
So how do we treat non-union? Does it depend on where it is?
Yeah, the treatment does depend on the location. For non-unions at the waist or distal pole, we usually do screw fixation and bone grafting. But for proximal pole non-unions, those are trickier because of the blood supply. So we often prefer vascularized bone grafting along with screw fixation.
Can you tell us a bit more about those vascularized grafts? What are our options?
There are a few different options. There's the 12-Vulgaros 2 intercompartmental supraretinacular artery graft, or 12-2 ICSRA, the 2-all-3 ICSRA, the free medial femoral condyle vascularized graft, and the pronator quadratus graft.
So the surgeon chooses the best graft based on the patient's needs and their own preference. This is a lot of information to digest, but it's all really important stuff for the FRCS exam.
You know, we talked about the anatomical snuff box during the exam, but it's so important. I think we should talk about it a little more. It's a really high yield area for the FRCS.
Yeah, you're right. It's a super important landmark. Can you remind us where it is and why it's so important when we're dealing with scaphoid fractures?
Sure. So the anatomical snuff box is that triangular shaped space on the back of the wrist. It's on the radial side, near the thumb. And it's formed by the tendons of 3 muscles, the extensor pollicis longus, extensor pollicis brevis, and abductor pollicis longus muscles. It's important because the scaphoid bone sits right underneath it. So if someone has tenderness in that area, it's a good sign that they might have a fracture.
So for us plastic surgery residents getting ready for the FRCS, we should really pay attention to any tenderness in the anatomical snuff box.
Oh, absolutely. It's a huge red flag. We can't ignore it. But keep in mind that just because someone has tenderness in the snuff box doesn't automatically mean they have a fracture. Other things can cause pain there too, like sprains or tendinitis.
Right, so we can't jump to conclusions based on just one finding. We need to look at the whole picture. A good history, a thorough exam, and the right imaging are all crucial to make the right diagnosis.
Exactly. Okay, so let's go back to why scaphoid fractures are more common in young men. We mentioned it before, but I think it's worth talking about a little more.
Yeah, it's helpful to understand why they're at higher risk.
So young men tend to do more activities where they might fall on an outstretched hand, like certain sports or jobs. It's a combination of their lifestyle and their anatomy that makes them more prone to these injuries.
And we also said that diagnosing these fractures can be tricky sometimes, especially early on when the x-rays might not show anything.
That's right. It happens a lot where we really suspect a fracture based on the exam, but the initial x-rays look totally normal.
So what makes these fractures so hard to see on those first x-rays?
There are a few reasons. Sometimes the fracture line is really subtle or even invisible on the standard views, especially if it's a hairline fracture. And the way the patient's positioned during the x-ray can also hide the fracture. If the scaphoid isn't lined up just right, we might miss it. And of course, there's always human error, Radiologists are great at what they do, but they're not perfect. They can miss a subtle fracture sometimes, especially if we don't tell them we're really suspicious of it.
So communication between the clinician and the radiologist is super important to make sure we don't miss anything. If we have a strong suspicion, even if those first x-rays are normal, we need to get more imaging.
Exactly. Now let's talk more about treatment. We talked about how important immobilization is for those non-displaced fractures. But how long do we usually do that for? That seems like a common question people have.
Yeah, I bet a lot of us studying for the FRCS would like to know that answer. What's the typical length of time we immobilize a non-displaced scaphoid fracture?
It really depends on where the fracture is and how bad it is, but generally we're talking about 6 to 12 weeks.
Why so long?
Well, we need to give the bone enough time to heal and become stable again. And immobilization helps protect the healing bone from getting re-injured, and it helps make sure it lines up properly. But we also don't want to keep it immobilized for too long because that can make the joint stiff and limit how well the rest moves.
So we need to find that sweet spot between early mobilization and making sure the fracture has enough time to heal. It's a balancing act. Now let's talk about displaced fractures. Those are the ones that need surgery, right? Can you walk us through the general ideas behind how we fix those surgically?
The main goal of surgery is to get those broken pieces of bone lined up perfectly and fix them securely. This helps the patient move their wrist early, and it lowers the risk of non-union, which is something we definitely want to avoid.
What are some of the things we think about when we're choosing how to fix the fracture?
We consider the fracture itself, where it is and how the bone is broken. And we think about the patient. How old are they? How active are they? Do they have any other injuries? It's really a personalized approach. We tailor the treatment plan to each individual patient.
Let's talk about those specific fixation techniques you mentioned before. We talked about percutaneous screw fixation. What are the advantages of that minimally invasive approach?
So percutaneous screw fixation means we insert a screw through a tiny incision. We don't have to open up the fracture site. That means less trauma to the soft tissues, less pain after surgery, and a faster recovery.
And when would we choose open reduction and internal fixation instead of the percutaneous approach?
We save open reduction and internal fixation for those more complex fractures, the ones where we need to actually see the fracture and move the pieces back into place, like fractures with significant displacement comminution or associated ligamentous injuries.
So open reduction gives us more control, but it's also more invasive.
Exactly. And whether we do percutaneous or open reduction, the surgical technique has to be perfect. We need to make sure the bones are lined up perfectly and that the fixation is strong. That's the key to good healing and good long-term results. And after surgery, the care is important too. Immobilization, pain management, and slowly getting the patient back to their activities. The exact protocol depends on what we did during surgery.
Now let's go back to those complications we talked about earlier: malunion, delayed union, and non-union. What are some of the things that make those complications more likely?
There are a lot of factors: how bad the fracture is, where it is, if there are other injuries, the patient's age and health, and really importantly, how well the fracture was treated initially. So for example, fractures of the proximal pole are more likely to have non-union because of that retrograde blood supply.
That makes sense. The blood flow to the proximal pole is already going in the wrong direction, so if anything compromises that flow even more, it's going to make those complications more likely.
Exactly. And delaying treatment is another big risk factor. The longer a fracture is unstable, the more likely it is to form scar tissue instead of bone.
So early diagnosis and treatment are so important. What about smoking? We always tell patients to quit. But how does smoking specifically affect bone healing?
Smoking messes up blood flow and oxygen delivery to the tissues. So it basically slows down the healing process. And that's not just for scaphoid fractures, that's for any fracture.
So that's another thing we need to consider when we're thinking about a patient's risk for complications. Okay, let's talk more about ethnicity wrist. We said that it's a long-term consequence of untreated scaphoid problems. Can you break down how this condition actually develops?
Sure. SNAC wrist or scaphoid non-union advanced collapse is a severe type of arthritis. And it happens because the wrist joint is unstable and the bones aren't loading properly. It all starts with a scaphoid fracture that doesn't heal right. And that throws off the normal mechanics of the wrist. So the carpal bones start rubbing against each other in the wrong way.
So a tiny fracture can end up affecting the whole wrist joint.
Yeah, over time, that abnormal contact wears down the cartilage. So the joint space gets smaller, you get bone spurs, and eventually you get arthritis. It's a slow process, but it can really affect a patient's quality of life.
And the symptoms can be pretty bad too, right?
Yeah.
Pain, stiffness, weakness, limited range of motion.
Exactly. It can make everyday activities really difficult.
So how do we treat SNSC wrist? What are our options?
It depends on how severe it is and what the patient needs. If it's caught early, we might try conservative things like splints, pain meds, and limiting activities. But if it's more advanced, we might have to do surgery.
What kind of surgery?
There are different options. We might do a limited wrist fusion or even a total wrist replacement. The best choice depends on how much damage there is to the joint, the patient's age, how active they are, and their overall health.
So there's a whole range of treatments, from
Mhm.
conservative stuff to complex surgery,
Yeah.
and we tailor it to each patient.
Okay, let's shift gears a bit and talk about the FRCS exam. What are some of the main things about scaphoid fractures that plastic surgery residents studying for the FRCS should know? You need to show that you really understand the anatomy, the blood supply, how these injuries happen, how they present, and of course, how to manage them.
What are some specific things about scaphoid fractures that are likely to be on the exam?
They love to ask about the blood supply to the scaphoid, specifically that retrograde flow to the proximal pole and what it means for fracture healing.
Why do you think they focus on that so much?
Because it explains why those proximal pole fractures are so likely to have complications like a vascular necrosis, delayed union, and non-union. It's a super important concept for understanding these fractures and why we need to treat them early.
What about imaging? What should people know for the exam?
You should know all the different X-ray views we use to diagnose scaphoid fractures, and you should understand why the dedicated scaphoid view is so important. You should also be able to talk about when we use advanced imaging like CT and MRI.
So it's not just about knowing the views, but also when to use the more advanced imaging. What about treatment? What are the key points for the FRCS exam?
You need to be able to tell the difference between how we manage non-displaced and displaced fractures. And you need to know when to operate and when not to. And you should know the different surgical techniques we use to fix these fractures and the pros and cons of each approach.
And we can't forget about those complications.
Right. You have to understand the complications, how to recognize them early, and how to manage them. That's crucial for any plastic surgeon. You should be prepared to talk about malunion, delayed union, non-union, and of course SNSC wrist, including the long-term consequences and the different treatment options.
So basically, anyone taking the FRCS exam needs to have a deep understanding of scaphoid fractures, from the anatomy and blood supply to the diagnosis, treatment, and potential complications.
Yeah.
All right, well, before we move on to some final tips, let's take a minute to go over the main points we talked about today.
Okay, so we started talking about how common scaphoid fractures are. We said they're most common in young men and that they're tricky to deal with in children because their skeletons are still developing. Then we got into the anatomy of the scaphoid. We talked about how its shape, its articular surfaces, and especially its blood supply are all important.
Right, and that unique blood supply with the retrograde flow to the proximal pole, that's so important for understanding why proximal pole fractures are so prone to complications. Then we talked about how these injuries happen. We focused on those two common mechanisms, hyperextension and axial load.
Right. And then we moved on to evaluation. We talked about taking a good history, doing a careful physical exam, and using the right imaging. We talked about why it's important to get multiple X-ray views and when to use CT or MRI, especially if those first X-rays don't show anything.
And then we got into treatment. We talked about immobilization for non-displaced fractures and the different surgical techniques for displaced fractures. And we emphasized that the best treatment depends on the fracture, the patient, and the surgeon's judgment.
And of course, we talked about the complications, malunion, delayed union, non-union, and SNSC wrist. We talked about what makes them more likely, how important it is to catch them early, and all the different treatment options from conservative stuff to surgery.
Wow, that was a lot. It really shows you how much there is to know about these little bones. Okay, so now let's wrap up this deep dive with some final advice for all those future plastic surgeons out there.
Here are a few things to keep in mind about scaphoid fractures. Always be suspicious when you're evaluating a wrist injury, especially if it happened from a fall onto an outstretched hand. Early diagnosis and treatment are crucial for getting the best results and preventing long-term problems.
What about imaging? Any tips there?
Don't just rely on the first X-rays. If you think there might be a fracture, even if the X-rays look normal, get more imaging or consider CT or MRI. Missing a diagnosis or waiting too long to diagnose it can have really bad consequences.
And what about making treatment decisions?
Every fracture is different and every patient is different. So you need to consider those things when you're deciding on the best treatment. And of course, use your own experience and judgment as a surgeon.
And last but not least, what's the most important thing for our listeners to remember as they study for the FRCS exam and get ready for their careers as plastic surgeons?
Scaphoid fractures are notorious for having complications, so you need to follow up closely with your patients and intervene early if there's a problem. That's the best way to prevent long-term disability and make sure your patients have the best possible outcome.
I think it's worth saying one more time, the scaphoid, it might be small, but it's a really important bone in the wrist. And because of its anatomy and its blood supply, it's really prone to complications.
Exactly. And that's why it's so important for you guys, as plastic surgery residents, to really understand these fractures, especially with the FRCS exam coming up.
Yeah, we've covered all the really important stuff today. Incidence, anatomy, evaluation, treatment. We talked about how crucial it is to get a good history and do a thorough exam. We talked about the importance of getting the right x-rays. And we went over to the main ideas behind treating these fractures both with and without surgery.
And remember, the earlier you diagnose it and treat it, the better the outcome for the patient and the less likely they are to have problems down the road. And pay extra attention to those proximal pole fractures. Those are the tricky ones because of that backwards blood supply.
Oh, and don't forget about all those vascularized bone grafting options. You want to know when to use those and why for the exam.
Definitely. All those details, plus a good understanding of the potential complications like malunion, delayed union, non-union, and SNXE wrist, will really help you on the FRCS exam and when you're out there practicing as plastic surgeons.
We've gone over a ton of information today, but remember, this is just the beginning. Make sure to hit the books, read those journal articles, and practice applying all this stuff to real-life cases.
Good luck with your studying.
And remember, everything you're learning now, it's not just for the exam. It's going to help you become the best plastic surgeons you can be. So that's it for our deep dive into scaphoid fractures. Thanks for listening.